For joining today. For the team from Novartis, I'm Sonal Gandhi. I'm one of the breast medical oncologists here and the quality lead for the division of Med Onc at Sunnybrook. And I'm very excited to welcome the Novartis team to talk to us about a unique opportunity to help integrate ribociclib as a standard of care for ER-positive breast cancer and really focus on the piece of cardiotoxicity monitoring. I don't have any conflicts of interest for this specific talk, but I've participated in Novartis ad boards in the past, as well as some for other companies as well. And I will say that some of the data I'm presenting today is kindly provided by Novartis. So what we're going to do is talk very briefly about kind of the position of ribociclib in the treatment of ER-positive, HER2-negative metastatic breast cancer, really on the heels of the updated MONALESSA data that was presented last fall. And then a specific focus really is going to be on kind of one of the practice and implementation pieces unique to this drug more so in terms of cardiac monitoring and particularly QT prolongation. And we have an exciting opportunity that Jamie Campbell and team will discuss with us about a sort of point of care innovation called Cardia Mobile, which may help us manage our patients better. And then hopefully we'll have some time for question and answer. And this is really meant to be an interactive sort of session for us to ask questions and understand how we might be able to use this tool. So as we know, with the updated MONALESSA data, there's really a significantly improved median OS with ribociclib in the first-line metastatic setting paired with letrozole. And I think it's quite compelling. We're used to using this drug as well as palbociclib, but I think in terms of where this is now positioned with this OS data, certainly we think that, it should be considered for many, if not all of our eligible patients, giving this compelling OS improvement. And here's a summary slide of kind of all of the data we have from the various MONALESSA studies, looking at ribociclib paired with the endocrine backbones that we're all used to. And I think for our purposes, from MONALESSA 2, which was updated. Again, here's the OS benefit that we've seen. But in terms of what the actual risk is in terms of QT prolongation, which is really the focus of the discussion today, the chance of having grade 2 or 3 QT prolongation, which we think may be clinically significant, is actually quite small. So, less than 4% grade 2 and less than 1% for grade 3 or more. And really no cases of torsade de pointes, which is really what we're worried about with QT prolongation, is that kind of very worrisome arrhythmia. And so we don't actually see that. The rest of the toxicity is kind of what we're used to with CDK4/6 inhibitors. And I think many of us have had enough experience with ribociclib now that we think in general, we're comfortable managing these things, but it's really that QT piece that at least at the beginning had made many of us nervous. And again, here's some some subgroup sort of evaluations of things like menopausal status, line of therapy, or endocrine backbone, demonstrating that the ongoing benefit of ribociclib. So I don't think from an efficacy perspective, most of us need kind of convincing that this is a very useful drug. So what about QT prolongation in terms of kind of practical management? And there is some kind of, there's some guidelines out there, and the product monograph also kind of gives us some guidance as to what to do. So really at baseline, I think this is one of the barriers that we sometimes face, is trying to establish, what is the risk of someone having meaningful QT prolongation? And so in terms of some of the guidance, really should only initiate it if someone's corrected QTc is less than 450 milliseconds at baseline. And the monitoring really has been to do an ECG with QT evaluation at baseline, kind of 2 weeks in. And many of us bring back our patients anyways at this time to look at things like blood work and liver function and CBC. So that gives us an opportunity to evaluate their ECG and their QT then. And then the start of cycle 2. And in terms of electrolyte monitoring, again, optimizing a patient's electrolytes really it speaks to trying to, minimize any other contributing factors to QT prolongation. The other piece, obviously, which isn't captured here is, a good medication history. And this is why, collaboration with our pharmacy team is really important to establish what the risk of other drugs may be in terms of prolonging QT as well. So again, as per the monograph for ribociclib, it's captured in here sort of, if we need a reminder, what we should be doing in terms of monitoring these patients. So at baseline, day 14, beginning of cycle 2, and then it's kind of a little bit more gray in terms of how often you might want to do it. And I think this might be dependent on the patient's risk. So are they on other drugs that prolong QT, that sort of thing. So, what do you do if you do have to manage a patient who has QT that's prolonging? Well, dose reduction for kind of grade 1 QT prolongation is appropriate. And we do know dose reduction for toxicity, including kind of hematologic toxicity, doesn't compromise efficacy. So again, we can do that safely and keep our patients on drug if we need to. I wanted to just kind of end with, what's out there in the literature about cardiotoxicity in general, just to put this in perspective, because I think, this has been this has been kind of in the spotlight as one of the barriers potentially to using ribociclib regularly. And there's lots of stuff out there, but I kind of like this abstract from ASCO 2020, which looked at all 3 CDK4/6 inhibitors that we generally use, as well as trastuzumab, another cardiotoxic drug that we have a lot of experience with. And so they actually looked at the FDA adverse events reporting system, which is a public dashboard in the US. And over 2018 and 2019, there were 27,000 adverse events related to CDK4/6 inhibitors, of which almost 3% were cardiac. So again, a very tiny fraction of what we're used to managing with these drugs. And the most common actually were atrial fibrillation, MI, cardiac failure, and pericardial effusion. And I always wonder, largely a menopausal population with risk factors for cardiac disease. So it's interesting to know, how they would have ascribed these particular endpoints to the drug itself, but still, that's kind of how it's been reported. It's interesting that the risk of cardiac AEs in this kind of evaluation was highest with ribociclib, but if you kind of look at the numbers, so palbo, bema, ribo, trastuzumab, still small, okay, ribociclib with a composite cardiac adverse endpoint was 7.9%, but serious cardiac adverse events was actually, in terms of absolute numbers, lower than palbociclib and lower than trastuzumab. And cardiac deaths, again, comparable to palbociclib, I would say, and again, less than trastuzumab. Again, I would take this kind of with a grain of salt because we don't know how they define this in kind of the context of the patient having other cardiac risk factors. But I thought this was a neat sort of summary just to tell us that, serious cardiac events are rare. And even if ribociclib compared to the other CDK4/6 inhibitors has a higher risk of cardiotoxicity, it isn't something that we should be fearful of because it's probably not as clinically meaningful as we might think. So I think in terms of a practical piece, the updated OS data is compelling to consider. And I think, our group spoke about this recently, and we all came to the conclusion that it's probably a preferred option for many of our patients. Taking into account cardiotoxicity is important. And obviously someone who's at high risk for it, we may prefer perhaps one of, perhaps palbociclib, but significant toxicity is still infrequent. And now the access piece to ribociclib has been really well streamlined. That was one of the other early implementation barriers. So we have bridge supply while we wait for EAP submissions, and many private drug plans really cover this with no issue. We have great kind of collaboration with our pharmacy team in terms of pathways to help manage these patients. And many of us kind of have our own algorithms within that as to how often we bring people back. But the ECG evaluation piece kind of remains one of the big sort of bottlenecks, particularly these days with, COVID and other healthcare resource issues. we're finding that getting an ECG is an issue. And I think that's where we're positioned to talk about today is, are there other ways for us to be able to monitor our patients in a timely manner, keeping these kind of resource constraints in mind? And I think that that's really the crux of it is, why are we even talking today? Well, does point of care assessment for QT prolongation or baseline QT assessment kind of help revolutionize the way we might be able to manage patients on ribociclib if we're going to be using it more often? Obviously, kind of the implementation aspects of a new device, we would have to discuss further, but today is really a discussion, and now I can hand it over to Jamie to introduce our guests today, the Novartis team, to talk about this unique opportunity, their learnings from it, and Dr. Osborne's one of the cardiologists who works with the team, and we're happy to have him join as well to kind of talk about what we can do to make things better for our patients. I'm going to stop a share here and hand it over to you, Jamie.
Great, thanks, Dr. Gandhi. So first off, thanks for inviting us here to speak with you, your colleagues here today, and certainly excited to share details about a program we've created at Novartis to assist centers like Sunnybrook with the sort of bottleneck ECG problem that exists out there. We call it CARE, and looking at Sunnybrook's vision statement today, and just the fact that you want to invent the future of healthcare, I think it aligns nicely, and excited to share the details with it. But before I do that, just brief introduction of who I've got on the line today to address any questions your team might have. We've got Gregory Roca, who's going to do the bulk of the presenting. He's the brand manager, but also closest to the CARE program. He's going to share the slides. We've also got medical here, Ankur Bodella, but certainly happy to have on the line from Market Dynamics, the medical director and lead cardiologist, Dr. John Osborne, on the line, as well as Kyle Hardy, who's the director of network operations. So, and for those that don't know who I am, I'm Jamie Campbell. I'm oncology care consultant with Novartis. Really just going to try and field the questions from your team, but the aim is just what you said: explore the CARE program that we're offering centers like Sunnybrook, see if it fits, go through the details. We're going to do a live demo and show the functionality of it, as well as see how it might fit within Sunnybrook, but hopefully leave lots of time at the end for discussion and address any questions your team might have about it, and leave it today with that, and hopefully look at how this CARE program might be able to implement and solve this bottleneck problem that you talked about at Sunnybrook, and see how it might benefit your patients. So that's it in a nutshell. With that, I'm going to kick it off to Greg to share his screen. And again, thanks for taking your time to join us today.
Perfect. Jamie, just confirm you can see the slides.
Again, that's great.
Yeah, perfect. Yeah. So thanks again for the opportunity. What I wanted to do first, before we go any further, is just a quick overview of what this CARE program is, or what this ECG device is, so we're all on the same level playing field. So as Dr. Gandhi eloquently mentioned, Kisqali does in our product monograph have an ECG requirement. Now, to help facilitate your journey with ribociclib and for your patients and throughout the care, this device can facilitate these ECGs, specifically for the QT readings. So it is a Health Canada approved device, a Class 2 device, and it does have experience in Canada, specifically with Novartis and this program. We started it in June in Quebec, and we were piloting it and learning and trying to figure out the best way that this program can operate. And we have about 20 devices now in Canada, but specifically in Quebec through this pilot. So it's basically a very simple and fast way to obtain an ECG reading. Reduces wait time, delays, burden, all of the things that Dr. Gandhi mentioned that could be bottlenecks for yourselves and your center. Now, what's important with this program is you do the reading on the device, which we'll show you a demo shortly, but you also have the results sent to the cardiologist, Dr. Osborne, who's on the line, is going to speak in a few minutes, to calculate this QTCF reading. And then this is returned back to the oncologist, to yourselves, and where you can continue patient care in a timely manner. So to do this program, all it takes is an attestation form signed by a medical oncologist. And the reason for that is, and I just want to make sure we're all clear, is as a pharmaceutical company, we cannot give medical devices away. So this is classified as a medical device, but we can definitely loan it to yourselves and to the center to help patient care once you've made the decision to use ribociclib. So that's kind of what this attestation form signs for. And basically it's all done at no cost. Novartis takes up the cost. And one thing to keep in mind is there is no patient information being stored on the devices. So it's all through a secure portal. You would get the results back, but it's no patient information, just an identifier where you can be able to track the ECG result that you get back. So a couple concerns that have come up in the past, we want to make sure, again, everyone is comfortable and is on the same level playing field. So the device I talked about is Health Canada approved. The cardiologist, Dr. Osborne, he will introduce himself and speak in a second, but he is a cardiologist from the US. The QTCF reading that is provided is a non-diagnostic reading, a specific calculation, and it's not considered to be a medical act or a diagnosis tool or a complete ECG workup. It's really to give you the reading so you can continue on with your treatment and with your patient care. In terms of the ECG liability, when this reading is done, and Dr. Osborne, I'm going to invite him to speak in a bit, as I mentioned, he will take a look at the interval. But if any other abnormalities are found, it is flagged. It is recommended a full cardio workup be done at your institution. So again, there's no circumventing or trying to interfere with your local cardiology department. This is really to facilitate this reading, the calculated reading, and then you continue patient care. And if there's abnormalities, it will definitely be flagged, and full cardio workup can be done at your center. So in a nutshell, 30 seconds you do the ECG at point of care, and then within 15 minutes you get this cardiologist calculated interval, so you can continue with that care. How this process works is, this first step is there is a device. So the device looks exactly like you see on the screen, but essentially it is a small little device like this that's Bluetooth and has a battery similar to a watch battery, so it's good for up to 2 years. And there's a mobile app that you have on your phone, whether it be iOS or Android. And essentially the patient performs the ECG. So one finger on the left, one finger on the right, and on the back, it goes on your left ankle or knee, directly on the skin. And then the ECG is performed. The reading you can see is done. It is sent to the cardiologist, and within 15 minutes, you get the results back. It's that simple. We'll do a live demo in a few minutes, but it's really a simple, clear, very easy program to run. Patients are very easily able to conduct this ECG, and on the app itself, it shows the steps by steps. And if you're not holding it properly, it will not be green. It won't proceed further, and it'll tell you, please, adjust your grip that you're using the device for. So, let's just go back. When you get the results back, you will log into a web secure portal at a certain website, and basically you'll have credentials to log in. This is what it looks like. And then when you log in, you'll see a dashboard, essentially of all of the ECG readings that have been done. So you can filter on the time, the date, on the patient. Here it's a patient name, but it's a patient identifier. It could be AA or letters or numbers or any kind of combination. And then you would click to see the results, and essentially you would see the full result with, again, the QTCF reading clearly marked on it. So then you would be cleared to proceed further with ribociclib, or any other comments would be made. So with that, unless there's immediate questions, I just wanted to maybe pass to Dr. Osborne, let him introduce himself, and if he wants to share a little bit of his experience to date with the device, the program, maybe mention a little bit on the frequency of abnormalities he's seeing, and then we'll go into a live demo and go into a bit of a discussion.
Sure. Well, thank you, Greg. I'm John Osborne, MD, PhD in cardiovascular physiology, and have been the medical director now for Market Dynamics for 11 years. We have really been very dedicated to using and integrating some of the latest technology and into making everybody's lives easier, faster, cheap, and along the way cheaper as well. To integrate safety protocols, particularly in the cardiovascular world. We have been using a variety of devices to monitor EKGs for various programs with various different pharmaceutical companies. We've been partnered with Novartis for about 11 years now and work with a variety of other companies looking at particular drugs that may have cardiovascular profiles that we need to monitor, like QTC, et cetera. We have been doing this program now with Kisqali, with the cardio program, with the cardio device since September of 2020. We've done over 1,200 EKGs in that program. And with our other programs, we also extensively use the cardio device as well. In fact, it's pretty much taken over as the dominant tool for point of care electrocardiography when we need to measure, look for AV block or QTC or those kinds of things. So it's really been a remarkable device. And even in my clinical practice, it really has dramatically changed my clinical practice. It almost has become sort of a standard thing. Any of my patients with electrical issues, arrhythmias, AFib, et cetera, pretty much ask them all to have one of these devices. And now it's really a point of care tool. And then we have this Cardio Pro that allows us to be able to pull up that data very easily and simply in a secure manner as well. So we have been we've done over 1,200 EKGs with Kisqali in the program. And interesting, I can tell you, as far as looking at patients with importantly prolonged QTCs, where that would be, we need to change the drug or frequency of those kind of things. At least in clinical experience, over the last 1,200 EKGs or so, I've really only seen 2 patients that have actually prolonged their QT to the point where it might require modification of the therapy. At least that's our clinical experience thus far with both the device and looking at patients that might prolong their QTC on the drug. But it's really been remarkable. We'll see in our little demo how quickly that works. It's pretty seamless. In fact, I read 2 EKGs yesterday from Canada, and I think we got the results back in less than 2 minutes. And it's easy, simple, obviously cheap as well. And all this oriented around making sure that patient safety is number one, and that we can easily monitor this parameter and then make any appropriate changes if we need to in their clinical therapy.
Awesome. So maybe we'll stop right there. And Dr. Gandhi, do you and your team have any questions right now before we go into the demo?
No, thank you so much. Dr. Osborne, I was wondering if you could comment on when this device was developed. Mm-hmm. How is it kind of validated against the regular 12-lead ECG? Like, is there any data you can share, or is that something we can look up? And like, what's the reliability?
Yeah, so going back historically, the device was actually approved by the FDA as a single lead EKG using only lead 1 about 7 or 8 years ago. So I think it was 2014. And then the 6-lead device, which now gives us basically all the limb leads, including, importantly for QTC measurement, was approved in May of 2020. We then, realizing what the functionality of this device was, rapidly integrate that into our programs where QTC monitoring was important. So that's why by September of 2020, we had already integrated this device into our protocols and programs. The device has been extensively investigated. There's published literature, over 150 papers have been published with the device validating its accuracy. And specifically with respect to QTC, several papers have been published with respect to looking at and monitoring and measuring the QTC with the Cardia 6 device versus a standard 12-lead EKG, showing that the device is accurate and with the same degree of sensitivity and specificity as we have with a standard 12-lead EKG.
Okay, thank you. Did anyone else have any questions before we see the demo? Andrea, I know we chatted briefly last week with Jamie and Greg. Did you have any follow-up questions? I think Rosanna's unmuted as well.
My only question, and I think was addressed by the presentation, but was this issue of like, are we like a medical legal one, for example, is this a cardiology consult from outside of the country from someone who's not in Ontario? But it sounds like it's not considered a medical act. It's essentially providing a number for the test. And so I appreciate that was addressed.
Correct. Yeah, I can just address it quickly. Yeah, so it's not considered a medical act. So it's not a cardiology consult. It's really just a calculated QT reading. Luckily we have Dr. Osborne doing these readings, so it's done by a cardiologist, but it would not be considered a cardiac or medical act here in Canada or in Ontario.
I just had a question also about whether there were any specific types of patients where this wouldn't give us an accurate estimate of the QTCF.
Yeah, a good question. I think one of the nice things with this device versus a 12-lead EKG, obviously, it's quick, it's rapid, it's simple. There's no leads, no wires, no goop, all that stuff we use. The only thing that does require is you basically have to do a little maneuver where you put the device on your left, basically anywhere between the left knee and the left leg, or I'm sorry, left knee and left ankle. So any skin between the left knee and the left ankle. So what we do is we usually have patients put their left leg on their right knee and then put the electrode, there's a bottom electrode, there's 2 electrodes for the fingers or thumbs. And then on the bottom, there's an electrode that you apply to the skin. There you go, that's it. To the skin, again, no goop, no conductive gel or anything like that. And you just put that on the skin anywhere between the knee, left knee to the left ankle. So that's it, very, very simple. There might be scenarios where patients have mobility issues to do that. Another trick that I use as well, and it works better in the summer, and of course, remember, I'm from Texas. So if you're wearing shorts, you don't even have to put your left leg on your right knee. You just touch that electrode right on the left knee as they're seated, so they don't have to do that little maneuver if they have mobility issues or whatever. But really haven't run into any patients where that's been a problem getting a good accurate EKG from the device. And again, it's actually easier and simple, much simpler, and of course much faster than a standard 12-lead EKG.
And while you're doing the reading and you have your fingers pushed down, if ever at one point the patient releases one finger or releases it off their leg, the reading actually stops, and the mobile device will say, please adjust your grip, and then that 15-second reading will continue at that point only.
Correct.
Do you guys want to maybe do a demo, and then we can maybe talk a little bit more about the logistics of what it might look like? They tried to convince me to do a demo, but my device is in a box.
I think we're going to check to see if Kyle is healthy, right? Is that the plan?
That is the plan. Let me know if you can see my screen right now.
We can.
You are looking at my cell phone, and you'll notice the Cardia Station app listed there. That's what I'm going to go ahead and launch. Originally, it will ask you for your credentials to log in. I already have mine entered, so it's just gone ahead and brought me to the initial homepage here. And you've got the single obvious option of selecting record an EKG. And at this point, it just asks you for the patient's medical record number or ID. So I'll just go ahead and this is alphanumeric. You can enter whatever you need to enter in here. Select next, and this is when it advises you to touch the device to wake it up, and it will Bluetooth connect to that mobile device and just let you know that it's ready to start the recording, from which at this point is when you should have the patient hold the device and get in place to actually start the EKG. So you can see when I touch the electrodes, they light up green, and it wants to start the EKG when all 3 are lit up. So I'm going to go ahead and do that placement that we spoke of, where I'm just going to hold it against, I've got both my left thumb on the left panel and my right thumb on the right panel, and the top just placed against the top of my left knee. And as Greg stated, if the patient were to let go, it's going to stop and basically ask you to, depending how far you are into the EKG, it will prompt you and state it wasn't able to obtain the appropriate amount of data and you should redo the EKG. But yeah, if the patient lets go, it will stop the EKG, but we'll go ahead and run through the full 30-second process here.
And also you can see here, it's just your standard limb leads, your standard 6-lead EKG from with 3 electrodes that gives us a 6-lead EKG, and you can see leads 1, 2, and 3, AVR, AVL, AVF, just like your standard 12-lead EKG, except we're not going to get precordial leads, of course, but those for our purposes in monitoring QTC are really not relevant.
After the completion of the 30 seconds, it's going to give you their algorithm interpretation as well as the heart rate. You can expand to actually see all of the leads if you want, and you can scroll over to see the full 30 seconds. Otherwise, you're going to just press the complete button, and it's going to then ping Dr. Osborne to complete that QTCF calculation.
So on my end, I've got it. I'm pulling up the EKG right now.
And what I can do is I can log into Cardia Pro and actually show you the EKG as well as Dr. Osborne's overread.
And just to confirm to everyone, so now that the ECG has left the mobile device, it's all been erased off the app and off your mobile phone. So there's nothing stored on your phone or on that app. You really have to now log into this web portal that's secured where you would see the results.
Are we going to see what the web portal looks like? Okay, great. Thanks, Kyle.
Yeah, no problem. So I am going to go ahead and log in. Oops.
I beat you.
You beat me. Great. So this is the web portal. It's pretty basic. After you log in, all you're going to do is go to patients on the left-hand side. And I've done a few different tests in here already, but this is where it lists your patients just by ID. So if you had a lot of patients in here, you can search just by punching in their medical record number, patient ID at the top. Otherwise, once you've got your patient, you just need to click on them. And it's going to list all of their EKGs here. So if you had more than one, there would be a full list of EKGs. You can filter by date or reading or anything along those lines. And you just want to click on the EKG that you were looking for. And as we can see on this one, it does give you the EKG here, and it's got Dr. Osborne's read on the right-hand side, QTCF of 368. And it does allow you to download the ECG as a PDF and save it to your EMR system or whatever would be best for you at that point.
Yeah, or for instance, obviously we're going to give you the QTCF, but if there were questions or issues or whatever, you'll have a 6-lead EKG that you could then share with the cardiology service or whatever. So there is an enduring
and
material.
On the PDF, it does tell you the QTCF. It is listed on here normally. This is my demo account, so it doesn't actually have it on this specific one. But normally within this section right here, it will say QTCF and give you that reading that Dr. Osborne had on the Cardia mobile app that we just saw. It's actually normally listed right under the QT analysis as well. It will state QTCF of 368 in this one. So it's all right in front of you. It's a really quick turnaround. We set that 15 minutes, but again, as Dr. Osborne stated, it's normally a lot quicker than that. You do receive, Greg, correct me if I'm wrong on this one, but you do receive an email notification once the EKG the QTCF has been calculated by Dr. Osborne. So you don't necessarily need to sit and wait in this Cardia Pro portal to see and keep hitting refresh to see if it's been read. You will get pinged with an email that tells you the QTCF is ready for review.
No.
Is
No,
there
Kyle,
ever a
one-
time that this is not being monitored? Like, is there ever has there been any circumstances where someone isn't available to read it?
Right.
What
So
happened?
we do this. We have myself, and we also have another cardiologist. Well, he's an electrophysiologist as well, by the way. Both of us are trained. So we basically cover this program, not obviously not just for Kisquali, but for other programs, 24/7. So
Okay.
weekends, round the clock. So, and then we also do this not just obviously in Canada too, but across the U.S. So everywhere from the Northeast, all the time zones out to obviously we have Alaska and Hawaii as well. So.
And in terms of kind of a practical perspective, again, thank you to Andrea. She also sat in with me last week as we learned about this device for the first time with Greg and Jamie. So, and my understanding, Greg, Jamie, Kyle, is that we could either have one device for each oncologist or one device in a clinic. We could have one portal that's shared, or we could each have an individual portal. And some of the key principles are you would have to have the app on your phone, like, or whoever is doing the reading with the patient has to have the app on the phone, but nothing stored on the phone or the app. But you would also have to be careful not to use a patient identifier that's related to their PHI, I would say, in this portal, right? Because if you use the MRN now, their MRN is sitting in a web portal. And I think we'd have to come up with some sort of kind of nomenclature for these patients. So, you know, is it their initials and 1, 2, 3 or whatever? So those are some of the kind of implementation pieces. And you were saying, Jamie, in some of the centers in Quebec, it's variable. Like some centers have each kind of clinician has a device and other centers is shared. Can you kind of maybe go through that with the group a little bit as to what seems to work and how people in a center like ours, where there's, you know, several clinicians with clinics on various days. And in terms, I will comment too, in terms of our model, in terms of our kind of nursing colleagues, we have a rotating group of nurses as well. So if some of the centers have like a, you know, an individual who would be able to do it before the physician sees it, we don't have that opportunity as readily because we have different individuals who help support the patients from a nursing team perspective as well. So I don't know if you had anything to add there, Jamie.
Well, certainly we're looking at it from what works for Sunnybrook. So what we have the ability to do is provide you with as many devices as you need. Some centers have it so that individual med-oncs have their own account, and we could also have it as a shared account. And the phones can connect to any device. So I guess what I'm trying to say is we can mix and match it the way you want. I think maybe from an initial standpoint, it would be great to have one account and have one place where you go to the web portal to get your readings. You mentioned about how to differentiate between patients. So obviously that's something you guys will have to decide, because you know the way it would maybe work is you have one site and you can log in, but it's important to note also that you can I don't think it was mentioned, you can download the reading, right, and upload it into your EMR. There's that. But as far as functionality goes, we can, you know, if you have a couple nurses, they could each have a device. If you lose a device, we can supply you with another device. We really just want to make it work for you guys. And I think that's really that's what we're hoping today will launch off is that we just get it piloted. Like have maybe, you know, Dr. Gandhi, you take the lead on this and start it with, you know, you, and we see how it works, and then we can customize it moving forward. I mean, really, if you don't think there's a need for this, like, we don't have to do it. This is really just a service that we're providing that if there's a need, and it does sound like it just from Dr. Eisen last week about, you know, the cardiology clinic being closed, there is a need, but yeah, that's my long-winded answer to say we can customize it the way you want it.
And if I could just for clarity's sake, in case there's any question about this, it doesn't matter whether it's an iOS or Android system. The functionality of the app is basically the same. So it doesn't matter kind of whether they have an Android phone or an iOS. It's all the same. It's device agnostic.
And again, the app is like the actual conduit for the electrodes, right? That's what's helping with the reading, but the actual results going onto this portal. And I think that's the distinguishing thing there that is important to understand. So the device is functioning like your mini ECG machine, and if your phone is a mini ECG machine, and the device is like the electrodes. And so, and we can talk about that as a group in terms of how we would handle the portal and that sort of thing. But I just wanted to get a sense from, oh, hey, Maureen, thanks for joining. If anyone else had some thoughts, anybody, pharmacy, nursing, from the oncology perspective, if you had any questions, now is our time to ask the team of experts about if we are interested and they've already kindly, like I said, sent a device over. I haven't opened it just to see if this is something we'd want to pilot. And again, from the resource perspective, Andrea, I don't know if you have anything to add. Our sense is that the kind of ECG lab, cardiology sort of consults, resource constraints might be there for a bit. And even that notwithstanding, I think from a efficiency and patient-centeredness perspective, this might be nice not to have to send the patient down. I know personally I've had some challenges where, they go down, they don't have the sticker, they get sent back up, the ECG's booked the day after they see you. Like there's all these other kind of practical pieces that we could try and mitigate with this sort of option. I don't know, Andrew, did you have something to add?
No, I have a very basic question. I'm sure it's fixable, but like, how do you clean it between patients? Is it?
Yes, we asked that last week. Alcohol swabs or?
Yeah, just
wipe it off.
Alcohol swab.
All right.
So I literally have my Cardia 6L in my pocket all the time, and I use it all day during the day in the office as well. But basically, just take an alcohol wipe and clean it. That's it.
Thank you.
So I guess the obvious question is this something that you like? Do you think this would be a benefit to the patients at Sunnybrook if we move forward on this?
I think so. I think it's innovative and exciting, and I think some of us might want to read some of the validating papers, Dr. Osborne, if you would be able to provide, or Jamie,
sure,
the references just in terms of the kind of validation piece. And then I think we need to just explore a little bit more at our institution if there's any kind of implementation barriers in terms of accountability and safety. I don't think so, because it seems like Andrea was saying, this is just a tool for getting a clinical assessment, essentially a point of care, but it's not a consult. I think that's the one sort of thing we wanted to try and understand, because it's not a medical act. We should be okay. But I do know trying to have implemented other sort of technologies for patient assessment before, that there can be some things that we need to sort out with risk. Andrea, I don't know if you wanted to add something.
No, I mean, I've just been thinking about it. Like, frankly, we're all physicians. We could all do an EKG and, do
Correct.
this, right? So like, I don't.
Correct.
Like, this is just a portable EKG machine that we have the benefit of EP specialists telling us the QTC. So, I mean, maybe I'm naive, but I think this would be a big benefit for our patients. Like, everybody hates going for those EKG, and it's
absolutely
kind of a waste. So I would like to try it.
And certainly from our end, being the center of excellence in breast cancer that you guys are at Sunnybrook, we would certainly support any way that you go moving forward, how many devices you want. Just that the learning itself would be great, and to share amongst your peers at Sunnybrook as far, and maybe, because who knows what this device is going to look like a year from now, right? But you guys are at the cutting edge of it, and I think the learnings would be amazing. just moving forward. So yeah, and being patient focused and patient centric, the learnings would be great for us from Novartis to have as well. So that's my pitch. But yeah.
And I'll say incidentally, it's also remarkable too. Whenever you bring this device out, anybody who's had an EKG in the past, like, which is probably most all these patients at some point, they're always like, wow, that's amazing. That's incredible. And I say, yeah, this is where technology's taking us, making things better, simpler, easier, cheaper, faster.
Yeah, absolutely. And Andrea brought this up the other day. The Apple Watch can now take your ECG, right? So many of these patients may already have one of those on too. So I think it's time. It's 2022. I think, let's embrace this. This is fantastic. Thank you guys. I think we were certainly, Andrea, I was certainly interested when Jamie talked to me about this a couple of months ago. So I thought it would be really great for the group to hear about it and get everyone's questions and engagement. Dr. Osmond, it's really great to hear your perspective, that you use this regularly as part of your practice.
Yeah. In fact, just as an interesting aside, for a slightly different use, the use of Holter monitoring in my practice basically collapsed once the Cardia 6L was available. Because I just tell them, buy this on Amazon. It's $149. You can keep it forever. You can do unlimited EKGs. And whenever you have a palpitation, arrhythmia, AFib, whatever, you can do your EKG right then, and it's just fantastic.
I just looked it up today. It's $99.99. I'm gonna get one for my husband.
Okay. There you go. So yeah, no, it's fantastic, and I encourage anybody that has one of these, if you haven't played with it, Dr. Gandhi, take it out of the box, because it's kind of fun, and it's just remarkable when you use it. It's incredibly simple to use, and just remarkable when you go, holy moly, with this little device, there's my EKG like that. It's phenomenal.
It's definitely
exciting stuff.
I think this is great, and I see from some of the chat comments too, people are interested. So maybe what we'll sort out, Jamie, offline is I'll just kind of chat with the group a little bit more. We'll figure out how we want to do this. If we want to just start with a couple of us, or all of us, like there's 6 of us, right? So it might just be a matter of if we all try it. I think it might be great, because I think it's going to change how we're able to manage our patients on ribociclib quite quickly. So is there any other questions? And then we can chat a little bit more, and then I can be in touch with you, Jamie, about how we get this set up. And you just so each individual person would have to get this and sign the attestation, I guess, the contract or whatever that is. Is that how it works?
Certainly, we can talk about those details.
Okay,
it depends how many accounts you want to set up.
Okay.
But I mean, one learning is, and honestly, if we want to implement that at Sunnybrook, and we shared it as well, is who's going to manage it, right? Is it going to be the MEDOC? Is it going to be nursing? And just, from pilot standpoint, it's okay if it's just one, but certainly, pre-printed orders maybe if it's nursing, because obviously it's the benefit for the patient's pretty easy to figure out, even for the medical oncologist. The nursing, you know what? But my wife's a nurse. I think there's a benefit there because nurses are patient-centric, and that patient that goes down for 2.5 hours comes back with the wrong ticketed ECG. So I think there's a benefit for the center as a whole to use the device. But honestly, a learning is who's going to manage it, and moving forward from there. I think that'll expedite it, and yeah, that's just my suggestion.
Absolutely. No, and I think, as I mentioned before, given just the way our model is right now, given the rotating and, just trying to keep track of where the device is and how, whose phone is it, I think we might just start with, if everyone agrees, I'm open to any other kind of suggestions. If we can pilot it with a couple of the medical oncologists to get a sense of it and how it fits, and then we can talk about how we might scale it up or, keep it. Maureen's asking, can it be used for any other patient other than ribo use? I mean, I don't see why not. Like if you're worried about something, if you have the device, I don't know, but I think, I don't know what the limitations of the program itself is, Jamie, in terms of the fact that this is a service that Dr. Osborne and team are providing for ribociclib patients. Like, what is the sort of restrictions around the device piece?
I'll let Greg answer that.
Sure, I can jump in, and Jim, you can finish up. But essentially, as Novartis, as a pharmaceutical company, the one thing we have to keep in mind is we cannot, by the rules and regulations, we cannot try to replace or circumvent, interfere with the healthcare system. So we cannot be providing these devices to then take away from the healthcare system of providing ECG. So that's the one thing to keep in mind. So that's why it was developed where, you know, your intentions are to use, you know, Ribociclib for your CDK, and then this is to facilitate that journey. So we're not trying to, you know, create a monster where we're replacing ECGs at Sunnybrook or for all patients. So that's the fine line. We just need to make sure we're not putting this program at jeopardy.
But I will add this. It's Sunnybrook's device. Is what, you know, if and we're patient centric. So if you feel a need, that's what I'll say on that.
Dr. Pezzo brought up a good point too in melanoma. We have to do a baseline cardiac assessment on patients on BRAF inhibitors, right? So MEK inhibitors. So I think that's a discussion, Rosanna, perhaps we can discuss more. I think we can chat about this a little bit this is why I mentioned the implementation piece. We might have to hash out a little bit more. From a QA perspective, we might just have to kind of make sure that we're using this for our ribociclib patients primarily, because that's the construct of the care program. But let's see how it goes. And if we have one portal, it might be easier to kind of do a QA versus multiple. But I think we'll get consensus from the group, because I think this is for all our patients. So we need to sort of figure that out. Thank you, Dr. Osmond. That would be great. And I'll share those resources to everyone who's interested. I'm just mindful of the time. And we can certainly have a follow-up chat, Jamie, I'm assuming, if we need to.
For sure. Whenever you need that.
Yeah,
and we can save all those other questions for offline too, right? But yeah, I'll just leave it with this. We want to make it work for Sunnybrook if you find the need. So, and again, being the center of excellence in breast cancer, I think the learnings are what I'm excited about and how we can further improve patient care moving forward. So, yeah, excited.
Yep. No, I think we all are. I think this was, I'm glad we were able to get this session in. Thank you very much, Novartis team, Dr. Osborne. This is exciting. I think I have a feeling we'll be able to use this for our patients, but we'll chat a little bit more about the nitty gritties. Stay well and safe, everyone. And
Try it out.
Okay, we'll do.
Thanks for your time, everybody, and appreciate it.
Everybody.
All right.
Thank you for that.
Thank you.